Good evening, everyone. ಈ ಶುಭ ಸಂಜೆಯ ವೆಬಿನಾರ್ಗೆ ಎಲ್ಲರಿಗೂ ಸ್ವಾಗತ. ಇವತ್ತು ರಾಮನವಮಿ, ಸೊ ಎಲ್ಲರಿಗೂ ರಾಮನವಮಿಯ ಶುಭಾಶಯಗಳು. We, Fogsi Kalaburagi, in association with Genetic and Fetal Medicine Committee, has organized a web talk. So today, Dr. Pratima ma'am and Dr. Supriya ma'am will be talking or teaching us about the first trimester anatomy scan, a basic scan. Ma'am, Pratima ma'am and Supriya ma'am, we Fogsi Kalaburagi team and all the members of Fogsi, and I think many of other people have joined here. So we will be thankful for lending your valuable time and knowledge to us. So I welcome all the other delegates who have joined to today's webinar. Now, our President, Fogsi President, and she is also a Genetic Committee and Fetal Medicine Chairman, will be introducing our speakers.
Yeah. My namaskarams to all the delegates who have logged in. Such a pleasant evening on such a pleasant occasion of Ram Navami. And we have logged in on this auspicious day to kickstart our first program under the Committee of Fetal Medicine and Genetics with none other than the pioneer in our state, Dr. Pratima Radhakrishnan and Dr. Supriya Sheshadri. We welcome you both, madam, to this wonderful program and having shared the platform with us and being always energetic, enthusiastic, sportive, and with innovative ideas and infusing the thought of going ahead with this program from the day one that I accepted to be the chairperson of this committee. You have put in a lot of ideas into this, and it is possible today to start this program. And the learning programs are always so happy, and especially so when we try to keep updated ourselves with all the accessories needed to enhance the care of our patients and to help have them a good baby. And Dr. Pratima Radhakrishnan, she wholeheartedly accepted to take up the idea of having the digital platform and connecting with all the obstetricians of the state who are doing their own ultrasound practice. The idea was that to empower all the obstetricians to be able to do the scans by themselves in the first trimester and to maximize the diagnosis so far as the fetal anomalies are concerned. So it's been her idea that we'll start with these sessions of first trimester and later propagate as we go on, since the tenure is for 2 years, to expand more and more into this learning process. And actually today, when I was talking to Dr. Pratima, she said that all those who log in today will see that they become well equipped with the knowledge and they can put it into practical use. It is not just we give a bhashan on the platform and leave and go. This is the word she said. And we also have the idea that those who are interested in this platform to communicate, keep in connect with us in the later days also, so that we make it as a realistic program once the COVID scenario is off. It's very bad out there, and we really hope that this bad times will pass on soon, and in a month or 2 months' time, we'll be able to see each other and also help each other to learn more about this ultrasound programs. Now, ultrasound is almost an extension of our hands. Like we used to do the PV examination, now each one of us have a probe in the hand as soon as the patient is put on the table. So we hope that the concept which was put in will have a great impact, and all of us will be benefited with this program greatly. I heartily welcome you, Pratima Radhakrishnan ma'am, and I also welcome Dr. Supriya Sheshadri to tell a few words about Dr. Pratima. In fact, she has a long CV, and her secretary has requested me to cut it short and said that please highlight only the important points. So the important points that we know about her is that she is a specialist in fetal diagnosis and therapy. She's been the first in the state to do many procedures. She's been the first one to be trained in fetal medicine, and right from the father of fetal medicine, that is Professor Nicolets. She has performed successfully advanced invasive procedures and pioneered the first trimester screening and diagnosis in India. She has several international, national, and regional presentations in fetal medicine over 16 years of period. She has been, her role models have been Professor Nicolaides and Professor Lindsay Allen, and she has an accredited trainer for various certification courses by FMF. So this is in short about her achievements, accomplishments, and she has held various international and national posts. She's been a ICOG ambassador in India and a fellow representative for the South Zone of AICC RCOG. She's been the advisor for genetic. She is our privileged advisor for the Genetic and Fetal Medicine Committee of Kasoga. Thank you so much for being on board, madam. We also have another speaker today, Dr. Supriya Sheshadri. She is trained in obstetric ultrasound of Fetal Foundation in India under Dr. B.S. Ramamurthy sir. She's trained in fetal echocardiography in Mediscan Chennai, trained in gynec ultrasound at Milan Fertility Center, Bangalore, and she's a consultant sonologist in Manipal Hospital, Milan Hospital, Bangalore Fetal Medicine Center. She's a trainer in obstetric ultrasound at FFI. She's the editor of e-newsletter that is Fetalog, and she's a speaker at various conferences. She's been a faculty in various workshops conducted by GE as well as the simulator-based workshops. She's been a program director for gynae ultrasound programs on-site and online programs. And she's been an expert trainer for stimulator-based transvaginal gynae ultrasound examinations. So we have two stalwarts on board today, and I'm extremely grateful to both of them for having accepted our invitation. I would fail in my duties if I not remember our stalwart in the Kasoga, Professor M.G. Hiramat sir, who has been the advisor, the guidance, the guiding force for us to be doing these programs and asked me to help the FAs at the Genetic and Fetal Medicine Committee. And our president, Dr. Sajjan, and secretary, Dr. Bharti Rajshekhar, have conveyed their greetings and have expressed their inability to log in at the moment. So I welcome you all once again, and keeping up with my young, dynamic, energetic, and enthusiastic secretary of Gulbarga OBG Society, Dr. Sanjana. You have been a darling, and all the team members, the Vice President, Usha Dodmani, Dr. Mangala Rudrawadi, my dear friend, and all the energetic members of the Gulbarga OBG Society. It's been a bundle of energy. I welcome you all to this interesting program. And personally, I feel this is a very informative program of practical significance in day-to-day lives. So the concept of inverted pyramid to diagnose the early complications and predict the anomalies and also prevent the early onset complications has revolutionized the obstetric management. So now we have the experts who will be doing the job for us. I request Anand to please start the program by lighting the lamp.
Sadgamaya tamasoma jyotirgamaya mrityurmamritam gamaya Om Shanti 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 Asatoma.
Today's date is a wonderful date, 21/4/21, and 21/4 looks like Ram. So what a coincidence. Thank you, Anand.
Thank you.
Yes, over to you, Sanjana.
Ma'am, nice welcome by you. Now, today's chairperson for this session are Vidya ma'am. Welcome you. Hello, ma'am. Hello, Vidya ma'am. So today's chairpersons, Dr. Vidya Dubey ma'am. She is a professor and unit head in Department of OBG, Alamin Medical College, Vidyampur, and She is a chairperson for Food and Drugs Medical Surgical Equipments for committee for Fogsi Committee 2018 and 20. She was an organizing chairperson for Kasoga 2016, and she was a president of Bijapur 2009 and a secretary of by 2017. She was a national corresponding editor for GOGI, and also she is a governing council member for ICOG 2021 to 23. She has presented many papers in national and international conferences, and she has organized many CME workshop and awareness program. She is advisory faculty of Rajiv Gandhi Health of Sciences, and she's an examiner for postgraduate, undergraduate, and also a teacher for over a period of 30 years. Vidya ma'am, I welcome you for this session. Hello ma'am. Connect again.
I think she's connected.
Hello.
You go ahead, she'll be listening.
Okay. The next person is our own Madam Haridan Dynamic. So she's the most dynamic, ever-loving, charming, and very helping to all of us. That is Rajeshri Paladi Madam, who is a professor and head of the Department of OBG, KBN Institute of Medical Science, Kalaburagi. She is a Fogsi member for the past 27 years and secretary of OBG in 2009 and 11. Presently, she is a Fogsi president and also a fetal medicine and fetal genetic, and also a genetic and fetal medicine committee chairperson. She is an executive committee member for Kasoga from past 2009 to 14. She has organized, that is, a Silver Jubilee State Conference along with all of us in the year 2014, when I think, madam, this was supposed to be hosted by other branch. The last moment you took the charge and we hosted this conference, and it was one of the successful conference. And mainly you and Meenakshi madam were together organized the conference. So she is a faculty in various national and international conferences and active participants of Fogsi and Kasoga event for past 20 years. She is a UG and a PG teacher and an examiner for many states like Karnataka, Maharashtra, Telangana, and other universities. She has got many publications in national journals, and she is an active member of Rotary and also vice president of Rotary Club 2020-21. So Pratima ma'am, with this thing, I will give this platform for you to begin this class and Bekar ma'am and talk and Beka, because you'll be teaching us and we'll be learning from you.
Thank you very much, Dr. Sanjana. First of all, heartiest congratulations to Dr. Rajeshri for taking over as the Fetal Medicine Genetics Committee chairperson of Karnataka. And I think this is really a good move that you have taken up this post, and which gives me a lot of hope and which gives me a lot of positivity about doing a good job in fetal medicine and fetal ultrasound as far as Karnataka is concerned. So I'm congratulating you, and I'm also wishing you a lot of best wishes for a very successful tenure. And I'm sure with the kind of enthusiastic people you have, it will be a great 3 years for Karnataka in fetal medicine. And it's nice to see a lot of familiar faces and names. It's become like that now, at least names and faces, if you see on Zoom, that also feels very good. So with that, let me just get on with the first talk of the day, followed by which Dr. Supriya will be presenting the next talk, and then we're going to end it with some case discussion. So we decided that we will keep it short, we will keep it very focused with respect to first trimester, and we're just going to stick to the anomalies. And let me see the time. So, well, there is plenty, but we are trying to kind of concise everything in a very short time. So bear with us if I just go off at a tangent sometimes. But I'm sure we will have many more of these, webinars in the future as well. And the idea is to be able to empower obstetricians to be able to do some basic level scans of good standards, of high standards, so that we can reduce the load on the radiologist, who can then concentrate on higher end scans and things like that. So and basically it's to optimize the scans of the fetus. Okay, so in this talk, we're going to concentrate on the congenital anomalies, and that we are going to talk about structure. So I'm going to concentrate primarily on the ISO guidelines of the first trimester scan, which came out in 2013. Now, when should we do it? It's done between 11 to 13 plus 6 and approximately 45 to 84 millimeters of the CRL. And the aim of the first trimester scan is to establish your gestational age accurately, determine the number of fetuses, evaluate the gross anatomy, which is what we are going to concentrate, and of course the risk of aneuploidy. And it is very, very important that every mother who is undergoing this scan must have a good counseling on potential benefits and limitations of the scan, and Supriya is going to take us through that as well. Now, who should perform it very clearly defines who should be performing as well, and of course the people who are trained. And of course, you know, doing a first trimester scan is not something that just you listen to a lecture and be done with it. It needs some amount of training to recognize normal as normal and abnormal as abnormal. And if you find something suspicious, what do you do? So it's very important to have a completed training program. And this is what I was discussing with Dr. Rajeshri earlier today. And, you know, she's been very cooperative and said that, yes, we should do something like this for Karnataka and, you know, get people trained in basic scanning abilities, or basically to recognize abnormalities and then refer them to the higher centers or more specialized people. It's of course very important to participate in continuing medical education activities, which I think we are getting better and better at that. We have established a appropriate care pathway. So if you have a suspicious finding, where do you refer them to? And of course, participate in quality assurance, because it's not just about doing the scans. We have to continuously audit ourselves to ensure that we are performing the scans adequately. It also describes which ultrasound equipment you should be using, and it is nothing very fancy or very expensive. Of course, you should have the basic 2D scans, transabdominal, transvaginal, because many times you may need to resort to transvaginal. Good power outputs, standard displays. Very importantly, you should have the freeze frame, zoom, cine loop, electronic calipers, and of course, very, very importantly, regular maintenance and servicing. AMC is very important for these machines because they are expensive. They need to be looked after well. They need to be taken care of like the babies themselves. And what are the things that we need to document? And it's on the electronic or paper documents. It should be stored. And according to the PCPNDT rules, also we have to store the records of the patient for at least 2 years. And of course, the records should be available to the woman and the referring healthcare. And they come up with a nice protocol-based report format that can be adopted by all. Now, one of the questions frequently asked by parents is the ultrasound safe? Of course, it is safe, and one has to stick to the ALARA principle. B mode and M mode are safe. Doppler uses higher energy, but if it is used clinically where it is indicated, it may be used. And if there is often, there can be situations, especially in the beginning of your practice, where you're not able to complete the examination as per the guidelines. And it is very important that we document the reasons why we are not able to complete it and then refer to the higher center. Of course, that has to be ASAP, because many times you're not able to see a structure like the way it should be seen, is because there is likely to be an abnormality there. And therefore, it is better that we refer them soon so that they can be, the anxiety also can be reduced of the parents. Now, determination of chorionicity, the multiple pregnancy for chorionicity, amnionicity must be done at this stage itself so that the antenatal care can be planned. So the guidelines, and I'm going to take you through these, are the assessment of viability, early pregnancy measurements, first trimester measurements. Dr. Supriya is going to take you through that. Assessment of gestational age, assessment of fetal anatomy, I'm going to take you in this lecture. We have kept the chromosomal abnormality for later on. Okay, so guidelines. So when we start the scan, it's very important to show the mother the heartbeat. So you're showing the mother heartbeat, she's happy and she says, oh wow, my baby is alive. So you see it on the sagittal, and then you can zoom it in the axial view as well. You're seeing it nicely, and you click on the thing. It sounds really good, and they are happy and they're a little bit more relaxed, and you measure the heart rate indeed. Now, early pregnancy measurements, before 6 weeks, we measure the mean sac diameter. But once we cross 6 weeks, and the moment you see a fetal pole, it is going to be the CRL that you're going to be measuring and checking the heart rate. So once you see the baby, then you have to stop measuring the mean sac diameter and just go for the CRL, because that is what is going to be used to date the pregnancy. Now, in the first trimester, we measure the CRL, the nuchal translucency, the head measurements, and of course the uterine artery Doppler. I have added on the abdominal circumference primarily because there is now emerging data in evidence that the measuring the abdominal circumference in the first trimester will give us a lot of information as well. Now, the other thing which I like about measurements is that when you measure something, when you're measuring the head, when you're measuring the abdomen, because you're seeing the stomach bubble there, you have measured it in the correct view. And therefore, the moment I have measured something, because I'll always measure abdominal circumference only when I see the abdominal stomach bubble. If I don't see the stomach bubble, I will not measure the abdominal circumference. So in a fetus, if I have measured the abdominal circumference, I know for sure I've seen the stomach bubble. Similarly with the head also, because all the measurements have got standardized planes. So if you take measurement of something, then you know that you have measured it in the correct view. Therefore, taking measurements and documenting these measurements is extremely important. It's not enough to say that you have just seen it. Like, for example, many times they say liquor is little less, little more. What does little less and little more mean? You have to measure it. Then only it is objective, right? And that becomes good for comparison and to know the trending as well. Now, coming to the gestational age, in the early pregnancy, before 10 weeks, we're measuring the CRL. And after, again, beyond 10 weeks, you can see that the caliper placement is much more accurate as compared to in early gestation. And the accuracy in the first trimester is within plus minus 5 days. And therefore, checking the gestational age, even at the time of the nuchal translucency scan, is far better than before or after as well. Right? Now, coming to the anatomy, the baby is fully formed by 11 weeks. So head, body, 2 hands, 2 legs, the spine, the kidneys, the spine, the bladder, and the cord insertion. All these can be seen in the first trimester itself, and that can be very reassuring the vast majority of the pregnancies. Now, coming to the chromosomal assessment, you have the NT, you have the nasal bone, you have the ductus venosus, tricuspid valve Doppler that will help you do the risk assessment for chromosomal abnormalities. I have not included this other intra and extrauterine structures, but it's good practice to look at any fibroids and any uterine abnormalities, your ovaries, etc., because this is a good time because you'll be able to see across in a panoramic view as well. So now coming to the assessment of the fetal anatomy. Now, as I said, at this time, it's important to check your gestational age. Obviously, you have ensured that it's an intrauterine pregnancy. If you have more than one fetus, you assess the chorionicity, you measure the crown rump length, nuchal translucency, other markers, and here in this talk, we're going to concentrate on system-wise assessment of the baby. Now, coming to the head and the brain. In the head and the brain, you're looking at the cranial ossification. You're looking at the cranial ossification that is complete. You're looking at the lateral ventricles. The lateral ventricles fill the choroid plexus, fill the lateral ventricles here. Okay, so the choroid plexus are almost reaching the edge there, and it is symmetrical. And importantly, you're seeing the midline end to end. So you have the cranium, you have the midline, you have this choroid plexus which fill the ventricles, and a little bit you go down, you will see the lower the thalami and the and if you're closer to 13 weeks, you probably will see the developing cerebellum there as well. So you're looking at all these structures as when you're looking at the head and brain and ensuring that they all look normal. Now coming to the neck, it's important that we make sure that the neck is properly aligned, that you see the neck in the neutral position. And because you are measuring the nuchal translucency in the neutral position, that's when in this position, you would measure the nuchal translucency as well. Now, in the axial view of the neck, you will look for jugular sacs. Now there is more evidence that you can take lots of measurements of the brain, that is the intracranial lucency. You can measure the BS-BSOB ratio, and you look at the maxilla, and make sure the maxilla is complete so that there are no clefts. And of course, you're looking at the chin also. So if there is any micrognathia, you're able to make out. Now, it's very important that you zoom the image well and see all these things very clearly, because when you zoom the image, you can see all these parts of the brain in a much, in a very, very clear manner. So it is important that you zoom all your images and make sure this image fills the screen as you are watching it. Now, coming to the face, here you're making sure that there are two eye sockets. You're going axially down from the head. That's the skull, the midline. And as you're going down, you're making sure there are two eye sockets. And at 13 weeks, you'll be able to see the little lens in the eye as well. And as you're looking at the eye, you look at the interorbital distance as well, because 1, 2, and you will be able to fit in another eye there. So here you're able to see the nasal bone in the axial view, although the nasal bone is always visualized in the sagittal view as well. Sorry. Okay, sagittal view. So if you want to look at more things, you can go down and look at the prenasal triangle. You can look at the lips, and you can go and look at the mandible as well. So these are the extra bits that is possible to do. Now, coming to the spine, you look at the spine in the longitudinal and the axial view, and if you reduce your gain, many times you will be able to see the sharp structure of the spine, the bright white spots. You're making sure that the spine is normally aligned, that there are no curvatures and unnecessary curvatures, and the skin is nicely covering the spine. And look at the BPD also in these cases, because sometimes when the BPD is below the 5th centile, there could be an associated spina bifida, and therefore look at it, look at it even more carefully. And you're looking for abnormal curvatures like kyphoscoliosis and any interruptions in the spine. Okay. Then coming to the thorax, thorax is seen in the axial view, is seen in the axial view of the heart itself. So here you're looking at the two lungs, which are homogeneous. You're making sure that there are no black spaces, that is the pleural effusion. And then once you go to the sagittal view, you're making sure that the diaphragm is continuous and there is no interruptions. And of course, in the axial view, here there are no black spaces that could indicate presence of the stomach as well, and the heart is leaning towards the left side. So these points you will make out in the thoracic examination. So the heart examination is also pretty much in the same, the 4 chambers of the heart. You're ensuring that it is normally placed, the cardiac activity is present, of course, symmetric 4 chambers, and we measure the tricuspid regurgitation you look for the tricuspid regurgitation in this view. Now, it is possible, we have done our little study looking at use of color Doppler in the first trimester to detect outflow tract abnormalities, and you can just put in your color and you can see beautifully X and V signs, which will indicate the intactness of the outflow tract as well. And this is just a 12 weeks and 1 day fetus, of course. Okay. So coming further down, there is a hypoechoic area in the stomach, in the fetal abdomen, and that is almost always stomach, and it is towards one half of the stomach, slightly posteriorly. And further down, you will see further below there, hypoechoic structure will be the bladder, and it is abetted by the 2 umbilical arteries. Now, if you're lucky, you would see the fetal kidneys as well, and you can put in color and look at the renal vessels as well at that time. These are little extra bits and pieces that you can do at certain times when you have a high-risk woman, or somebody who's had a previous affected pregnancy, and you can be quite reassuring to the mother that it's all looking good in certain circumstances. So it is possible to do all these things in this scan. Okay. Now, coming down further to the abdominal wall, it is important to look at the abdominal wall, the cord insertion into the abdominal wall, and making sure that you're looking at the inside and, sorry. Yeah, so you're looking sure that you're seeing the cord, umbilical cord inside the fetus and outside the fetus, and that the skin is coming there and touching the cord. That means there is no exomphalos or no gastroschisis. And of course, as you're doing that, you're looking at the umbilical cord as well to ensure that there are no cord cysts. And the most commonly placed cord cysts are closer to the closer to the cord insertion, because we know the presence of cord cysts increases the risks for aneuploidies, particularly trisomy 18, and of course also increases the risk of miscarriage in these pregnancies. Coming to the fetal limbs, it's very important to look at all the three segments, that is both the arm bones, both the forearm bones and the fingers there, and the legs, the thigh, leg and the knee, and important to make sure you're seeing them both. And this is the best time, of course, to count your fingers and toes as well, because almost always the babies will keep their hands up there and you will be able to see them. So as you're looking at the arm and you're looking at the forearm, just count the bones of the forearm and make sure that the hands and legs are aligned properly. And at this time, because there is still plenty of fluid around the baby, you will be able to see them much better than in mid-trimester or late pregnancy. Coming to the 3D, 4D scan, it is not routine first trimester evaluation. The resolution, of course, is not as good. You will get a good 3D, 4D only if you have a good 2D resolution. And of course, it may help in detection of surface anatomy. So just coming back to that, so you see the skull, you see the midline, you see the choroid plexus filling the ventricles, going down axially, you see the two eye sockets, and look, just observe the interorbital distance. You're coming up, you're seeing, sorry, you're going down, you see the upper lip, going further down, you see the heart beating, and heart is pointing towards the left, and these are the lungs there, right? And as you go further down, you will see a stomach bubble, and the heart was also, remember, pointing to the same side, and the stomach is also on the same side. Coming further down, you see the umbilical cord insertion, right? And little bit down as well, you see the fetal bladder and the two thigh bones, two knees, and little down, and you see two little feet there. And sagittal view, you see the bladder come to one side, you see the arm, two bones of the forearm, fingers, go gently to the other side, and you see the arm, two bones of the forearm, and fingers. So pretty much your anatomy is done within 2 minutes. And really, you did not require the baby to be in perfect position to be able to see this. And just baby many times gives a little jump, and you're making sure the spine and intactness of the diaphragm, the stomach is below, the heart is above. So pretty much you have done your entire anomaly scan in this short time. So it is extremely important to understand that this is your best opportunity, especially as well, to assess the fetal anatomy. Early reassurance helps vast majority of our patients, because most of the babies we know are normal. So in the presence of normal anatomy, the risks of aneuploidies is also quite low, right? Now, and very importantly to remember that not all anomalies we can detect. We can detect a lot of major abnormalities, but not all abnormalities. And follow-up scan, even after a normal first trimester scan at 18 to 20 weeks, is an absolute must, right? So I would encourage all of you to go to, I've shared this with Dr. Rajeshri, and she will share with you the fetal log, which was very elegantly edited by Dr. Supriya, where Dr. Anita Shettikari has put in an article about the target 9, which I'm going to talk about in my next talk as well. And this will happen only if we do a good first trimester anomaly scan. So with that, I'm going to end this talk of mine, and we can decide whether we want to take questions now or we take questions later.
Hi, Rajeshri.
Hello.
Yeah, hello.
Yeah. Go on, madam. Vidya, madam.
Yeah. So Good evening, everyone. This is Dr. Vidya Thobi.
Hello, Dr. Vidya. Yeah.
Hello, Pratima. How are you?
I'm fine. How are you?
Yeah, fine, fine. So it is very nice to see you on screen, off the screen. Your
Thank
hands
you.
are like Jadugar, I must say. So whenever you hold the transducer, everything becomes so clear. And your talk was really excellent.
Thank
It
you
is
so much. Thanks so much.
always love to listen to you, Pratima.
Thanks
And,
so much. Thanks.
aptly, Dr. Rajashri had chosen you as a first of her webinar, and your advisory, your everything for us. So she has taken up this fetal and genetic chairperson as a chairperson, and I know that she will do wonders.
It's
And-
my honor, Dr. Vidya. It's my honor.
Yeah, definitely. And we will launch some of this certification courses through Kasoga as well. A shorter one for the clinicians. That will be better. Means that will definitely boost our practice also.
I think Dr. Shubha, somebody wanted to see the.
Yeah. Some audio disturbance was there, and that's
Audio
why
disturbance.
there was.
Dr. Shubha, I have put in the format here, but you will get this, if you just go to the ISO guidelines. I think I will share that. I'm sorry, I missed it. I will share that with you. Or let me see, I can try and share it on the chat screen here itself. The paper on the first trimester scan 2013, the ISO paper. I'll do it. I'll
Can you send to us by mail also, Pratima?
I'll do that. Yeah, I'll do that. Yeah.
Yeah.
And I
So
will share it
those
here
who
also
want to
because I think
please,
in chat I can share it, I guess.
Yeah. So that can be shared to everyone, I feel.
Yeah.
A message I would like to convey to the participants that at the end of the program in the chat, there would be all the 4 Fetal papers which are published by the Center of Dr. Pratima, and you can download them and go through them for your references at the end of the session. Yeah, madam. I think we'll take the questions at the end of the session.
At the end of the session, that will be better. We move on to our second topic.
Dr. Supriya.
Dr. Supriya's talk. Dr. Supriya is, welcome, Dr. Supriya. I need not introduce you again because already Dr. Rajashri has enough. She has told about you, and all Karnataka people know you very well. I have listened to you in Muscon at Bagalkot, and it is really great to listen to you. So over to you for our second talk, and let us listen to Dr. Supriya.
Supriya ma'am?
Yeah, I'm just
Can you share your screen?
sharing my screen.
Yeah.
Ma'am, ಕೇಳಿಸ್ತಾ ಇದೆ Supriya ma'am?
ಕೇಳಿಸ್ತಾ ಇದೆ.
Okay.
One sec. Can you see my screen?
Yeah ma'am.
You have started screen sharing now.
Yeah, but it's not going up. Looks like I'm frozen.
It will come up.
Yeah,
Anand, guide ಮಾಡ್ರಿ madam.
It's open. Madam, please enlarge your presentation.
And
Slideshow.
put it in slideshow. Yeah.
Oh, one sec.
Madam, slideshow on the top after animation, slideshow option is there.
Is it okay?
Done.
Yes ma'am, yes.
Go ahead.
Good evening, everybody, and thank you for being here. At the outset, I'd like to thank the office bearers of Kasoga for giving me an opportunity to participate at this webinar. My talks are very simple, but they are very basic. And as you've heard from the previous talk, you will know why we need to get our basics very right in order to go further. So what is fetal biometry? It's all about measuring some anatomy of the fetus. Now, it is mandatory at the first trimester scan to measure the crown rump length, or what we refer to as the CRL. The other parameters which we so routinely measure in the mid-trimester, that is the biparietal diameter, the head circumference, the abdominal circumference, and the femur length, well, according to AIUM, that is the American guidelines, they recommend these measurements only if indicated or in suspicious cases. And ISWAC goes on further to say that there is no reason to measure these structures as part of the routine first trimester scan. So what is the purpose of fetal biometry? The prime purpose of fetal biometry in the first trimester is to assess the gestational age or assign an EDD. Now, we're all familiar with guidelines which say that an EDD has to be assigned anywhere from 8 to 13 weeks, 6 days. The best time is between 10 to 13 weeks, 6 days. But in our practices, since we see ladies at an early pregnancy scan, and provided we have done the early pregnancy scan right, we do assign an EDD based on the early pregnancy scan, either from the LMP, which correlates with the CRL taken. The CRL should be a minimum of 10 millimeter, or if there's a discrepancy of 5 days, less than 9 weeks, then we assign an EDD at the early pregnancy scan from the CRL. So in the first trimester, there are 2 scenarios. One is the lady's never had an early pregnancy scan, and therefore we are bound to assign EDD at this time. Or she has had an early pregnancy scan, and it is a good practice with all reports to include an image, because if there's a discrepancy at the first trimester scan, we should not brush it aside saying that it's a question of wrong dates. It could even be a clue to an abnormality. Therefore, first trimester scan EDD may correlate or may not correlate with that assigned in the early pregnancy scan. Now, why is EDD so important? It's important because we have to time certain tests. Now, the test that we do in the first trimester, as we are all familiar, is one is the nuchal translucency and the other is the serum screening or the double marker. The timing of these tests is again gestational age dependent. And having done the test, the interpretation is also the gestational age dependent, and therefore it's very, very important that we have the right EDD. Now, with this EDD going forward, we can see how the baby is growing, and any deviations from normal is always taken in relation to the gestational age, and there again EDD comes into play. Now, why not assign it later? We cannot assign it later because as pregnancy progresses, there's very wide variations in fetal size, and therefore an EDD assigned in the second or the third trimester will definitely be not as precise as that assigned in the first trimester. You must have all gathered from the previous talk, having seen the beautiful clips that Pratima played, that all that she did was go axial. Axial means take transverse sweeps, and other one is sagittal. Well, axial and sagittal planes are the very planes in which we measure fetal biometry. So it's akin to, like, getting 2 for the price of 1. So when we do a fetal biometry right, we are able to assess a lot of the anatomy, and that will definitely help in the correct diagnosis of normalcy, or give us, set up antenae if there are any abnormal findings. Plus, looking at biometry alone, which will give us clue to abnormalities, and we shall look at some of them later. Now, there are some general principles to fetal biometry, either if it's the BPD HC or if it's the CRL. The route of scan can be either transabdominal or transvaginal. The charts are the same for both. It's important that we get clear magnified images. That means the image optimization should be very good. You've heard that, but one cannot reiterate enough that there is no point getting blurred images, or no point getting images where the focal points are not right, or no point getting images which are very small, which you actually need to put on a magnifying glass and look at. So it's very, very important that we get clear magnified images. The landmarks must be clearly displayed. The caliper endpoints, again, should be taken as per the nomogram followed. Now, each institution have their own protocols. So some institutions take an outer to outer measurement, some take an outer to inner measurement, and it's important that this protocol of that particular institution is followed. The measurements may be done either in ellipse form or in the form of 2 perpendicular diameters. So coming to CRL, which is the most important measurement in the first trimester, there are 3 broad categories that we need to fulfill. One is all features relating to the image should be right. All features relating to the measurement should be right. And having done so, the interpretation of the CRL should also be right. So let's look at the image criteria first. There are 4 image criteria. One is, again, magnified image. Second, the fetus should be in a horizontal position. Third, the fetus should be in a neutral position. Fourth, and it should be the mid-sagittal plane of the fetus. So let's look a little, I think I'm having power issues. Anyway, so let's look a little more into this, each of these features. Magnified image means the image should fill in at least 2/3 of the screen. And I have displayed the same fetus in two different views. This is small and this is magnified. Now one can easily, I mean, there's no rocket science to understand that when the image is magnified, the caliper endpoints become very clear, as well as study of the morphology also becomes very clear. The second aspect regarding the image criteria is orientation of the fetus. The fetus must be horizontal, which means the long axis of the fetus should be perpendicular to the ultrasound beam. Now this again, no rocket science, because going by ultrasound physics on 2D, anything to be seen well, anything to be displayed well should be perpendicular to the ultrasound beam. Now having said that, a deviation of 30 degrees is allowed. Now for the purpose of this talk, I actually measured it. The angle is 140 degrees, which means anything more than 30 degrees from 90 degrees is not taken as a right image. The third image criteria is the fetus should be in a neutral position, which means neither flexed nor hyperextended. Neutral means there should be some amount of fluid between the chin and the anterior chest. The width of this fluid, it's again a subjective impression. Of course, there are studies which look at profile lines, but that's a little more complicated. When you look at a few fetuses and try and get a visual impression of what the correct fluid level should be, then you would know. Now the correct fluid means, you can see this bone here. This rectangular bone is actually the maxilla. So the fluid width should be equivalent to this rectangular bone. Now this is a hyperextended image, and why it's not right? Because obviously the CRL measured here will be much more than the actual. Now this again is a flexed fetus, which means you don't see any fluid between the chin and the anterior chest, and again this is not the right image for the CRL. The third, now I know this is a jumble, but then this is the scenario which some of us do come across, and there's always room for change starting from today. So this is a mid-sagittal plane wherein the fetal head, the face profile, the spine, and the rump are very, very clearly seen, and the whole fetus is seen, which means you must be able to see space beyond the rump, and you must be able to see space beyond the head. Now, one look at this, you know that all these are wrong. This is wrong, this is wrong. And I mean, I wish we were in an on-site or an interactive class where I'm sure they're very easy to come up with the answers why it's wrong. This is wrong because we don't know. I mean, I can't see the head at all. This is, I can see a line here. This is a zygoma. So when you see a zygoma, this is a zygoma, this is a zygoma. When you see a zygoma, that means you're parasagittal. We're talking about a mid-sagittal. When you see a zygoma, you're going parasagittal, and there again, the CRL tends to get underestimated. So here in this image down, I think I have to move my, okay, one sec. In this image down, I mean, you think you have a right CRL, but then I don't see any clear space beyond the rump, and therefore, again, this is not right. Now, this is an inverted. It may seem very well. There are options to invert this image, but remember the charts which we're referring to have not taken standards based on this kind of an image, and therefore, it's not appropriate to take this image for a CRL measurement. So having seen image criteria, let's come to what is a measurement criteria. Now, measurement criteria is the caliper placement, which means here they say horizontal, but ultimately when the fetus is horizontal, it's the vertical crossbar of the bar of the crossbar should be on the outer aspect of the skin at the topmost portion of the head and the lowermost portion of the rump. And this is a straight line measurement. The best of 3 correct measurements is taken. There are guidelines which in fact say that you can take an average of 3, but where I work and what is popularly followed is the best of 3 correct measurements. So this again is mainly taken for the top, where you say all these are wrong because this is not the topmost portion. This again is not the lowermost portion. And this again is incorrect because it is going any which way. So beware of images or beware of reports wherein you see images with these kind of measurements. Now, having seen 2, the third interpretation is also extremely important, but that's made very simple because once we take a CRL, there is a software on the machine which computes the CRL to a gestational age. And even if you don't have a software, there are external charts which will do this job for us. So once we know what the gestational age is based on the CRL, our next step is to see whether it correlates with the LMP or whether it correlates with the EDD from a previous scan. And again, look at all the background factors and see if you need to reassign an EDD or go with the EDD given earlier. Now, when I say background means it's, again, I'm reiterating, it's always a very good practice. And in fact, guidelines say that every report should be accompanied by images, including an early pregnancy scan. So when in doubt, always look at the images of previous, and then you will know that if there's really a difference in dates because of a pathology or a difference in dates because the previous measurements were not optimal. Now, when do we assign EDD? Because as I said, the main purpose of doing a CRL at this stage is to assign an EDD. There are two scenarios. We can assign an EDD based on an LMP or based on a CRL. Now, guidelines say that we can assign EDD based on LMP if the ladies had regular menstrual cycles, which means her cycle is anywhere from 24 to 32 days. She's not had used oral pills or not breastfed in the last 2 months. It's a spontaneous conception, and the difference in the CRL measured gestational age and that from the LMP is less than 7 days. If it is more than 7 days, then it is recommended that the EDD be assigned based on the CRL, and the accuracy was plus or minus 5 to 7 days. Now, CRL can be taken for assigning an EDD only if it is less than 84 millimeter. And very, very important, and one can't stress on this enough, is once a gestational age or an EDD is assigned, then going forward, it should not be changed under any circumstances when a discrepancy beyond the normal arises. So what's the other biometry? We talked about BPD HC, and it is a good practice to look at it even routinely, because although they say indicated, when it is really indicated, if we don't have the practice of getting a right one, then we will again be, going around in stormy waters. Regarding the measurement of BPD HC, there's a slight difference in the landmarks. At 11 to 12 weeks, all that's required, both are on what we call true axial planes. Now, when I say true axial, the midline forks should be horizontal or near horizontal to the ultrasound beam, and it should be symmetrical on either side from the calvarium. Now, at 11 to 12 weeks, the landmarks suffices the choroid plexus, but around 13 weeks, we should be able to see the third ventricle as well as the thalami, and it's only on this plane that we need to take the BPD and HC. So again, it is an outer to outer or outer to inner measurement depending on which chart is being used. And you can take an ellipse or you can take a straight line. Now perpendicular again, so widest diameter. So if I were to take perpendicular measurements, I will take one from here and another what is called the occipitofrontal diameter, and the machine will compute the HC from these two perpendicular measurements. Now the utility of using the BPD is sometimes try as hard as we might, we're just not able to get a right CRL. In those cases, a BPD really comes into handy, because studies have said that gestational age or an EDD aside from a BPD beat a CRL or beat a CRL BPD really is not there's not much difference. So one can use either of them, and also it's useful when this is a suspected anomaly. Plus, when the CRL is more than 84 millimeter, then one has to take a recourse to a BPD or a HC to measure the gestational age, to assign the gestational age and assign an EDD. Now, there's a big difference. When we do it in the second trimester, we take a composite of the average. That means we take an average of all the measurements, provided those measurements are all coming in normal. Whereas when we do it in the first trimester, we do not take an average. If you're not taking the CRL to assign EDD, then it's only the BPD and HC, or the HC, not both. And some studies have even gone far to say that HC is a little more precise than the BPD when it comes to assigning an EDD. So there again, very easy to understand why these are the wrong planes. Now, when we take a head measurement, it should not be distorted by the surrounding structures. Plus, there are no landmarks here. There are no landmarks here. And this is the midline forks is really not horizontal, it's more vertical. So these are all the wrong images. Now coming to the abdominal circumference, again, it's an axial plane with a spine either at the 3 o'clock or the 9 o'clock or the 3 o'clock position. The stomach bubble should be visible. The intrahepatic portion of the portal vein may or may not be visible. And it's important to see a single rib on either side, which means it's a true axial. Here again, it can be an ellipse measurement or it can be the widest diameter, two perpendicular widest diameters. And from these diameters, the machine will compute, or the external software will compute the AC and the gestation age. So again, the utility of this is not at all for assigning EDD, but suspicious findings will tell us if there is an abnormality, especially when there is a small CRL. Now here again, these are all the wrong Is there a disturbance from me? Okay, the spine is at 12 o'clock. There is no stomach bubble seen here. There is only one single rib or maybe even multiple ribs here. And here the spine is at 6 o'clock. So all these are wrong images. Coming to femoral line, now at this stage, the bones are extremely small, so they have no role at all to play in a gestational age. Now looking at the femur, sometimes it becomes very difficult even to measure the femur, and the utility comes when there's a past history or when there's a suspicion of skeletal dysplasia. Here again, the image should be magnified, and what is important is all these spurred artifacts should not be included. Here, in order to get as precise a measurement of the femoral length as possible, the femur should be again horizontal, which means it should be perpendicular to ultrasound beam so that the end points are clearly seen. If it is oblique, then there's a little shadowing from the bone. And it's only the ossified diaphysis, that means only the bright portion that's measured. So this again, although I measured, it's not really right because this is not occupying 2/3 of the screen and this femur is kind of oblique. So these two are not the right measurements. Now, fetal biometry does have add value. Now, in this case, as you can see from here, this was my glasses. This was a 12 weeks, 1 day, but on measurement, it was only 10 weeks, 5 days. Now, this lady I've been following right from the early pregnancy, and there was a difference in CRL right in the beginning. Of course, true to what we normally do, she had regular menstrual cycles. So I did assign the EDD, but when she came back for a subsequent scan, I found that it was not corresponding. So I went back and redid it, and it did not assign an EDD. Now, this fetus had no other problem. It's just that it followed her every 2 weeks. I think she went till 16 weeks. This growth lag continued, and so we told her that things may not really be going well. She had an invasive, and unfortunately it turned out to be a trisomy 18. Now this set of images, again, as you can one look at it, this head seems too large, and in these cases, try hard as we might, just not possible to get a right CRL. It's here that looking at other biometry pays importance. Now this is a 13 plus weeks. The BPD corresponds to 13 plus weeks, but if you look at the measurement of the AC and the FL, there are far less. So this was a clue to triploidy, and unfortunately this fetus did turn out to be a triploidy, had nothing else except this discrepant measurements. So a CRL less than 5th centile, suspect early fetal growth restriction, triploidy, or even a trisomy 18, and a BPD less than 5th centile is again a clue for spina bifida. It's not a very good clue, not a very specific clue, but it's a very easy parameter to measure in even the lesser experienced hands. And that's why, as I said, just measuring is not enough. Always look into what centile it is. And for that, you always have to have a right EDD. And to have a right EDD, you have to have the right measurements taken the right way. So in practice, crown rump length is the most important biometry that must be taken routinely in all the first trimester scans. The other biometry to be noted in indicated or suspicious cases. The CRL to be assessed with complete adherence to image measurements and interpretation. CRL to be used for dating when up to 84 millimeters. More than that, BPD or HC to be used. And once an EDD is assigned, it should not be changed thereafter, regardless of subsequent scan findings. Thank you very much for a patient hearing.
Talk, ma'am. Pratibha, ma'am.
Thank you.
Thank you. It was a really excellent.
Yeah, ma'am. Supriya, ma'am, it was a nice talk. Good
Yeah.
explanation, nice slides.
Yes.
Thank you, ma'am.
Thank you.
Okay, so we'll move on with the next
Yes,
part. I think people should just write down their questions
Yeah,
as
yeah.
we go
Here
along
only
so
one
that
question. Yeah, we can move. Yeah,
address them at the end.
Ma'am, last at last we'll discuss.
yeah, yeah.
That's right. I'm just
Please
saying
note
this
down,
right. I'm
Dr.
just putting them
Sanjana.
a
You can
reminder
note down
for
the
them.
questions. Yeah.
Okay.
Yeah, I request the participants to keep noting down the questions and put it in the chat box as well, so that Sanjana can take them up and we
Yeah,
can have an
chat
interaction.
box ನೋಡ್ತಾ ಇದೀನಿ. I am seeing chat box.
Yeah.
Yeah, yeah.
Okay, so
But
we
I
will
would
go
like
back
to congratulate Dr. Supriya for doing a wonderful talk and extremely clear, and everything seems so simple when you both display the images.
Okay.
Pratima ma'am.
Yeah. Okay. So we will move on to the anomalies that is detectable at the first trimester scan. Okay. Now, question comes: can we really diagnose structural anomalies in the first trimester, and can we really invert the pyramid of care, where we look after more women in the first trimester than we look after women in the end of the pregnancy, and so that we can triage them into low risk and high risk as we go along. Okay, and this is a part of that. So talking about early detection of anomalies, to summarize, it's between 45 to 84 mm and 11 to 13 weeks. And the reason why 45 to 84 mm is more for screening for chromosomal abnormalities rather than structural anomalies. So if somebody comes to me at 14 plus 5 and says that we want to do the first trimester scan, yes, I will do the scan. I will look for anomalies, the gestational age, we'll do the biometry. The only thing we won't be able to do at that point of time is do a risk assessment for chromosomal abnormalities. So the 45 to 84 millimeter is the window for risk assessment for chromosomal abnormalities and not for detection abnormalities, because obviously the abnormalities that are present at 65 millimeters will be present when the baby is 90 or 100 millimeters. Okay. Now, let's look at what is the evidence. There are plenty of papers and many papers coming regularly out suggesting that so many abnormalities can be detected in the first trimester, including cardiac defects as well. And this is the original studies were done in early 2000, and the Indian study where we had looked at 12,000 pregnancies, and we matched very well to 1.7% major 1.7% of abnormalities. The prevalence was 1.7, and about half of them were detected in the first trimester itself. So this is very significant and matched very well with the international data. So that's the same thing. And in the second trimester, we picked up another 40% of the abnormalities. In the third trimester, about 2%, and still there were 5% left in the postnatal period. So it's important to understand that not all abnormalities will be detected in the first trimester. There will be some in the second, some in the third, and some will still be missed in spite of going through all the good scans as well. So this is what this study taught us. Now, looking at Professor's study, this was about 45,000 pregnancies which were examined, which had their first trimester scan followed by the anomaly scan and were examined in the postnatal period. They removed all the aneuploidies because obviously aneuploidies will, because we were looking at non-aneuploidy, that means structural abnormalities. So prevalence was about 1.1%, about 43%, and 44% were detected in the first trimester. And what he did very cleverly, he put in as some abnormalities which can always be detected in the first trimester, and some which can never be detected in the first trimester, and others which are potentially detectable in the first trimester. So this demarcation became very good, that when we looked into our Indian study, the same applied to the same study, we also realized that we have the similar information, that almost all the detectable anomalies in the first trimester were detected in the first trimester itself, like the actinium, encephalocele, holoprosin-Kefli, exam follows all the gastroschisis, megacystis, and body stalk anomalies. So if you do a good first trimester scan, you will be able to detect them all. And what were sometimes detectable were some skeletal dysplasia, some diaphragmatic hernias. Sorry, it's bone shortening. Isolated bone, ISO is missing here. Isolated bone shortening, some is a polydactyly facial clefts open spina bifida. Where you look for it, you will find. And of course, there will always be some which will not be present in the first trimester, and they will be detected in the second trimester, sometimes even in the third trimester. Now, when we're doing the first trimester scan, it is very important to keep in mind two abnormalities. One, where the bladder is increased in size, but less than 16 millimeters. So it's megacystis, that is more than 7, but less than 16 millimeters. And many of them, about 85% of them would resolve spontaneously. Few of them will progress to severe hydronephrosis. Then you have exomphalos, especially with only the bowel inside. Over 90% will resolve by 20 weeks, whereas some will persist. And of course, if it contains the liver, or if it's a gastroschisis, then it's more likely to persist. So these two abnormalities are important to understand, that these have a high chances of resolution. And therefore, when you see a megacystis or when you see an exomphalos with only bowel, then it is better to wait, and review them rather than just terminate them in the first instance. Okay. Sorry. Now, we looked into the, the always detectable anomalies, and we called them target 9. And what we did in a population of 5,500 pregnancies, we gave this list of target 9 abnormalities to all the doctors who were doing the first trimester scan. So we collected this data prospectively. We removed the aneuploidies, and in the 5,500 pregnancies, there were about nearly 2% defects, and we had a high detection of abnormalities, because by this time we had learned many more tricks on the first trimester detection of abnormalities. When it came to these target 9 or always detectable 9, 41 out of the 42 abnormalities were detected. There was one which was reported as a cord cyst, which turned out to be an exomphalos in the second trimester, and that pregnancy continued, and they had a postnatal repair, and that kid did well. And in addition, we found many other structural abnormalities in the first trimester, because now we were doing focused first trimester scan. So the end result is that when you do focused first trimester scan, you can pick up many more abnormalities. What we did not detect in the first trimester were primarily clefts of the lip and the palate, talipes, hypoplastic left heart, bowel atresia, etc., which we know are more likely to be picked up in the second trimester. So we made a list of this always detectable 9, what I like to call target 9. So when you're doing your first trimester scan, you target and make sure that these 9 abnormalities are not there, so that you know very likely this baby is normal, because these are the ones that will certainly be picked up in the first trimester. So let's look at each one of them individually. So I told you the skull, the presence of the skull bone, the cranium entirely all around will ensure that it is normal. So when you don't see that skull bone, then that is a acrania. Skull all over, you don't see, and that is acrania. When you don't see only a part of it, and there is a brain that is jetting out, that is your encephalocele. I also like to call it the lady's bun kind of appearance. So you see the bone is coming there, and there is a gap there, and this is protruding out, and that is a encephalocele. And most common place to have an encephalocele is the occiput. Of course, you can have in the parietal, you can even have in the frontal bones, but 75% of encephaloceles are occipital encephalocele. Now, I told you that we must see the midline end to end. When you don't see the midline end to end, that you're coming here and it is just stopping, and there is no demarcation there, you see what they call as a monoventricle, that is a alobar holoprosencephaly, and we know that alobar holoprosencephaly is a lethal abnormality and associated with many chromosomal abnormalities as well. Okay, so that is. Now next one is where you're trying to get a good CRL, like how Supriya showed you, try to get a good CRL, but sorry, you're not able to get a good CRL and the neck is bent over. Of course, this baby is hydropic as well. So neck is fused and hydropic, and constantly the baby is looking back, and that is an iniencephaly. That is because of the fused cervical vertebra. Now, you're coming to the cord insertion. I told you that the abdomen, the stomach should be touching the cord there. So you're going into the axial view. You come down, that's the heart, and you come down. As you come closer to the cord insertion, you see this little bulb there, and that is the cord insertion, and that is a little bowel that is jetting out into the cord, and that is a small exomphalos. Now we must remember that is the small exomphalos, which has got a high association with chromosomal abnormality, primarily trisomy 18 and 13. But once you do a karyotyping in this baby and you wait for 16 to 18 weeks, majority of them will resolve as well. That is, the bowel only exam fillers are more likely to resolve. However, if you have liver in these exam fillers, especially that happens in large exam fillers, then it is very unlikely to resolve. So those ones are also quite surgical challenges as well. The other anti-abdominal wall defect that you would see is the bowels hanging loose in the amniotic fluid, and you see this like kind of ragged appearance, a cauliflower-like appearance, where the bowels are hanging loosely in the amniotic fluid. That is your gastroschisis. Now, gastroschisis is known to have low association with aneuploidies, but not no association with aneuploidies. It is surgically correctable, provided you have got good amount of bowel that is maintained well. But many times these bowels do tend to get damaged because of the constant exposure to amniotic fluid. So this must be kept in mind. However, generally, if I have a baby that is going to undergo surgery postnatally, I would always prefer to karyotype that baby and make sure that we have no additional surprises after the baby is born. Okay. Coming to the target 7, I said we should see all the limbs in all the 3 segments. And if you don't see the limb, any part of the segment that is missing, then you can pretty much pick up your limb reduction defects in the first trimester itself. Then coming to a, sorry, it's not a video, I think. Okay, so you see a large cystic space. Now, a large cystic space in the fetal abdomen is almost always a megacystis unless proved otherwise. And how would you prove that this is a bladder? You would just put the color flow on the in the axial view around the cyst, and you will see the umbilical vessels or the umbilical arteries abutting the cyst, and therefore you know that this is a megacystis. Now again, there are 2 types of megacystis. There is one which is less than 16 millimeters or 7 to 15 millimeters, and one which is, sorry, there should be 16 millimeters. So the bigger the megacystis, like what you're seeing here, the more likely it is an obstructive uropathy, whereas the smaller megacystis, which is less than 15 millimeters, they have a much higher association with aneuploidies, but also they are the more likely to resolve antenatally as well. So if you see a megacystis, you would karyotype that fetus and you would wait to see in about 3-4 weeks whether it resolves spontaneously, and many times it does. Now, body stock anomalies where you have a small umbilical cord. In this, you can see the baby's is almost attached to this is the baby and is almost attached to the placental surface, and of course clearly the baby's head looks abnormal and nasal bone is absent as well. So there is the baby which looks very small and very close to the placenta, which has got a short cord, and this is a short cord, and that is a body stock anomaly. So pretty much these 9 abnormalities on the head and crania and cephalocele, A lobe and holoprosencephaly, in the ventral surface, exomphalous gastroschisis, in the posterior part, iniencephaly, and further down, megacystis, limb reduction, and of course, body stock, the whole baby is very abnormal. So these are abnormalities that really you should be looking out for, especially as a beginner. Also, you will be able to pick up these abnormalities in your first trimester scan. So look out for them, make sure this is not there, and then very likely this baby is going to be normal. Now, apart from that, we can potentially pick up some more abnormalities, like, for example, in this baby, this is a very abnormal posturing of the limb. You will never see both the limbs stretched out like that and keeping it straight. And constant, I was tapping the mother's abdomen and kept moving it. So you see that movement, and it just would not stretch out its limbs. So this is a cyanomelia. Now, this baby was referred to us with increased nipple translucency. Of course, there was increased nipple translucency, but in addition, there was quite short limbs. I mean, you see the limbs, they look so abnormally small. The bones, you can hardly make out the bones. The arm, forearm, and fingers. And this is a 12-week pregnancy. And then coming to the lower limbs, you see again how short they are. The bones are really, really small. So this was, of course, a lethal skeletal dysplasia, which was detected in the first trimester. Now, spine, it's good to examine the spine directly. And apart from all the other markers, and you see this little bleb there, and you know that is a spina bifida. Of course, take the help of using transvaginal scans as well, where you can see the anatomy much more clearer, and use that. And here, of course, you can see that there is a kind of a in this, of course, there's an obliteration of the space as well. Now, coming to the left, you see this the profile, and you can clearly see a gap there that is called the maxillary gap, and this was indeed a cleft palate of the baby. Okay. Now you can see diaphragmatic hernia, which can present in the first trimester. You can see the heart is shifted to the right, and you see an echogenic space there, which is the nothing but the fetal stomach bubble, which is sitting in the chest. So that is a congenital diaphragmatic hernia. And when you see a congenital diaphragmatic hernia so early in the pregnancy, many of them will be associated with chromosomal abnormalities as well. Now, cardiac defects can also be detected apart from screening for cardiac defects, which is used by increased nuchal translucency, presence of tricuspid valve regurgitation, abnormal ductus venosus. These are all markers for cardiac defects, and the more number of markers that you see, the higher is the possibility of finding a cardiac defect in that. And of course, the X and B signs that I've already described to you. Now, there can be markers in the high risk group. These are again newer markers that can be referred to the expert to look apart from your increased NT and abnormal tricuspid valve and ductus venosus flow, which are markers for cardiac defects. If you have abnormal X and B signs, which are again markers for cardiac defects, you have a reduced IT, which is a marker for spina bifida, and maxillary gap, which is a marker for cleft palate, and further diagnosis can be made in conjunction with the expert or with the expert as well. So I think it's all about working together as a team, and as you do more and more first trimester scans, you get better and better at it, and then you become expert. So it's all about learning on the job, really. Okay, and so pretty much your first trimester NT image, the key process image, will detect so many abnormalities in the brain. Now you have your BS-BSOB ratio that we used, the single line, the Dandy Walker, the Burmese hyperplasia, Blake Scotch, megacystoma magna. Though you may not see it in this view, you could suspect it, and many of these will be associated with chromosomal defects. Now, for the open spina bifida, again, you have a high BS-BSOB ratio, and also the effacement of the cisterna magna. Then this is a normal line. So you're looking at all these lines. You're looking at the PMG. You're looking at the maxillary gap, and you can even look at the pericallosal artery at this stage. Though I don't really encourage looking much at the putting on blood in the first trimester, particularly when you're a beginner, because then you may put it for too longer time. Then look at for cleft lip and palate, and then of course for holoprosencephaly and possibility of absence of corpus callosum as well. So these are many things that are evolving in the field of fetal medicine and can be looked out for, particularly in the first trimester as marker, and have a closer follow-up rather than waiting for the anomaly scan at 18-19 weeks. You can bring these women back around 16 weeks and see them sooner, and make an early diagnosis, which is much safe for the mother as well. So your potentially detectable anomalies will depend upon what your primary objective of the scan is, what is your protocol that you have set yourself for, how much training you have had as a sonologist. Of course, transvaginal scanning is very good, but it would take extra time. Newer techniques would be helpful because there are many more newer 3D, 4D techniques which can help you, improve the detection of these anomalies. But it must be remembered that many defects may not be possible, some defects may not be possible to detect even by experts at this stage. And therefore, the limitation, which I think Supriya is going to tell us about. So once we find that abnormality in the first trimester, what do we do after that? Do we just go ahead and terminate that pregnancy, or is there something else that we need to think about? Now, this is what we did at PFMC. We looked at about 12,000 pregnancies. We looked at about 3% of structural defects, and about 78%, nearly 80% were isolated, and 20% had 2 or more defects. Now we looked at how many karyotypes were checked and how many had aneuploidies. So when you had associated defects, when you had 2 or more defects, the karyotyping was done in about 18 of the 78 pregnancies, and 60% had a chromosomal abnormality. However, when it was isolated, 40% had a chromosomal abnormality. But look at these numbers. Unfortunately, majority of the pregnancies are terminated without even checking the karyotype. And here we are talking about 40 to 60% of presence of an aneuploidy. So what does this tell us? This tells us that when you have a structural abnormality, it is very important to check the chromosomes so that you know what aneuploidy, because we all know, for example, Down syndrome, which is one of the most common aneuploidy, can present like hydrops in pregnancy. It can present as a cardiac defect. It can present as an absent nasal bone. And of course, Down syndrome babies are missed on completely normal scans. So it is the same chromosomal abnormality, but it can present in different forms in various fetuses. So therefore, what you're seeing as a chromosomal, what is the phenotype of this genetic abnormality may change in the subsequent pregnancies. So to me, termination should be absolutely the last order of the day. So if you find an abnormality, logical speaking should be to assess that abnormality completely and find out the cause for that abnormality, whether it is a chromosomal or associated chromosomal or genetic disorder, and then only talk about termination of pregnancy. Now, we also looked at, when we had isolated or multiple abnormalities, which chromosomal abnormality are we more likely to encounter? So when it was isolated abnormality, it was mostly trisomy 18. And when there were multiple abnormalities, most of them were trisomy 13. So Down syndrome can still have only markers with not very many structural abnormalities. So the conclusion of our studies said that the prevalence of aneuploidies is significantly high, both in multiple and isolated fetal defects. Trisomy 13 and 18 are the more frequently associated in these babies, even in the absence of markers. Remember, we removed the markers. The prevalence of aneuploidies is significantly high, 40%, even in the isolated group, and hence we must recommend karyotyping when we see fetal defects, irrespective of whether there are markers or not. And that will help us to assess what is the recurrence risk for that pregnancy. So what I would like you to take back from the talks is inverting the pyramid of antenatal care is here, and we all must learn to adopt it and shift our concentration of fetal and maternal care in the first trimester so that we can introduce proper interventions to make better outcomes of the pregnancy, both for the mother and for the baby. Majority of the major fetal anomalies can be detected in the first trimester, provided we know about them, we look out for them, and this will allow a safe termination of pregnancy. Target 9 must not be missed in the first trimester. We must be aware of in utero evolution of certain anomalies, and therefore this will reduce the number of unnecessary terminations. It is very important for us to train and update ourselves constantly and keep looking out for new markers and newer markers. And finally, whether it is associated or whether it is isolated or whether you have associated multiple fetal defects, we must karyotype this babies so that we know the cause for the abnormality and therefore take an action accordingly or help them in the subsequent pregnancies. So that brings me to the end of this talk. So that's it. Yeah.
Yeah. Dr. Supriya?
Yeah. I think to enable me.
I hope those who have logged in have reserved the questions for their end, and we really are looking forward for some very interesting discussions for the topics at the end.
Okay, thank you for being around. And limitations is something that we have to accept. I mean, we can't do away with it. And once we understand and accept, then it becomes easier to speak to our patients about their misgivings or their concerns or their angst when something is not going right for them. So I have grouped limitations into 3 categories. One is operator dependent, second is depending on the maternal features, and third is fetal. Now operator can be completely overcome, and I think, if I might say so, one of the good side of this pandemic is because of so many webinars and so many learning platforms, I think it's not an excuse to be not well equipped in doing a first trimester anomaly scan, whichever part of the country we are. Now, maternal features may or may not be overcome. Fetal features certainly cannot be overcome at the time of the first trimester scan. So let's look at each of these categories. Now, limitations which are operator dependent, again, there are 3 of them. Training and experience, most important. And although I was tempted to put it last, I think it should be all along. It should come first as well as last. Second is ultrasound equipment related. Here again, I think no excuse, because now companies are literally vying with each other to give us good machines within our budgets. And therefore, we have to make sure it's not as I say, a bad carpenter blames his tools. Well, it's not just the machine. We have to get to know how to use the machine. And third is the route of scan always should be very flexible to TS as well as TVS. Now, a little on training and experience, I've already said. Experience, again, is something that we build up along the way. So that's why every scan that we do in the first trimester, treat it as a detailed scan. For whatever reason she's come, and then with more number of scans, the skills improve. It's important on the time spent on the scan. Now, there are studies, which says 20 minutes, 30 minutes. I really don't buy that, because it all depends on the baby's position apart from the maternal features. So again, no point, having something else going on the side and then trying to do a scan. No, time on the scan should be a total focused time. The ability to communicate and counsel, again, is extremely important, because the end point of scan is just not doing it, writing a report and say, okay, now you take recourse with who has referred you. No, even if we don't talk to the patient, we should be able to talk to the clinician and try and explain if there's some abnormality in as simple findings to the patient, so that she knows what to do next. And again, even wherever we are, we have to have referral pathways for further investigations, whether it is a serum screening test or an invasive procedure, or even a genetic counseling. And there again, because of the platforms that we have, I think pathways are again very easy to come by. Coming to the ultrasound equipment, again, the machine should be accompanied with a TS and a TVS probe. There must be facility to store and print images. And as Pratima also has said, the machine should be maintained and the regular servicing should be undertaken. Now, it's important to use the correct presets. And this, again, our application specialist friends, they do an excellent job. There is specifically an NT preset, which will definitely make a difference when we're doing an NT scan. And image optimization, I can't say enough. Unless we know the knobs in the machine very well, then only we will be able to optimize an image and get the best out of the machine. So coming to the route of the scan, again, TES and TVS, normally the practice is to do a transabdominal scan, and in most instances, the scan gets done within this route. If for some reason the views are poor or we want to have a better view, then we do a transvaginal scan. Now, detection rate as per studies, when both the routes have been employed, is anywhere from 62 to 82%. When it's only TES, 51 to 62, I don't think so. I mean, probably Pratima may have figures for this. I think in our scenario, the figures are even higher for detection on a TES. And when TVS is only the route, 24%. That's easy to understand, because although the TVS has a good resolution, it doesn't have penetration. And plus, because of the limited space, the probe movement is not as great as when we do a TAS. TS, because it has a wide scanning field, we're able to get all the structures in one plane, and plus, switching to axial, sagittal, or again becomes very, the optimal axial and sagittal planes becomes very easy on a TAS. Now, this is an example of a TAS scan, and even if you have not done the scan, you'll know this is such a poor image for a CRL. So when I did a TVS, fortunately the baby was in a position, and this is the image that I got in a TVS. So be very liberal with the approaches of the route to the scan. The mental features that actually might limit a good image is body habitus, uterine fibroids and scars because they cause shadowing, a uterine position, there's a retroverted, not really because, at this time the uterus kind of starts becoming more horizontal. So I don't really think uterine position is such a great hindrance, but nevertheless, it is there. Transient myometal contraction, yes, this does come in the way. And as you can see, this is an image of a transient myometal contraction. Now, very often when we get the lady to pass urine and then she comes back for a scan, we find something like this. Well, don't even bother to spend time on the scan. Ask the lady to take a walk, eat something, and within 15 to 30 minutes, 20 to 30 minutes, the contraction will pass off, and then we get very good images. So again, when there are limitations due to mental factors, use TS and TVS, it's important to mention, and even with these, suppose we don't get good views, it's important to mention the reason. Now, for example, fibroids and scars give us horrible views even if we do a TS or a TVS. So mention the reason on the report, and always call the lady back for an early anomaly scan at 16 weeks. Now, I wish I could have interacted with you all and asked you, what do you think of this? These are images of the heart of the same patient. Of course, she's 14 weeks. This lady is a high BMI patient. She came around 11 weeks and we told her to come to 12 weeks later. Well, because of logistics of travel and the current scenario, she only came in 14 weeks, 3 days. Now, I was this image on the left, this is a high BMI patient. So this image to my left is taken with this. Yeah, this is an image borrowed from Professor Abu Ahmed, wherein he says scan below the panicles. So this image is taken where the probe is on the fat. And if very often, I kind of like this maneuver where I tell the lady to lift the fat up, and then this plane below is a very, very good scanning plane. So this image is actually got from the scanning plane. So again, use all these tips and tricks to get good images, because of metal features, it may not be that great. Now, fetal features is something that we really can't tackle at this stage, but we should be aware of what the fetal features are, because this again will help in the dialogue with the patient or with the referent clinician. So there are many of them. One is gestational age at the first trimester scan. Second is undetectable anomalies. They're so small that they can't really be seen at this stage. Evolving anomalies. They may be late onset anomalies. They may be late manifest anomalies. They may be resolving anomalies. That means we've seen something in the first trimester, but going forward, it's not there. And then what do we tell the patient? How do we explain it to her? The seventh point in a fetal feature of limitation is absence of indirect clues. And also there may be abnormal findings of questionable significance. So let's look at some examples. But all these limitations just tell us one thing, that we cannot do away with the mid-trimester scan. So this again should be explained to the referring clinician or to the patient that this is not the, yes, this is a good time to look at certain structures, but this is not the last time that we will be looking at all the structures. So gestational age makes a difference. And in this study, it was found that around 10 weeks, only 6% of the fetal anatomy could be studied, whereas in 13 to 14 weeks, almost 98%. That's rather high, but it's a good figure for all of us to target at, sorry. And 11 to 12 weeks, it was anywhere from 75 to 95%. Now, undetectable anomalies, meaning they're not present. So in this category, although Dr. Pratima mentioned, she used the word potentially detectable. Yes, sometimes you do get, we do get findings of CDH in the first trimester, but sometimes no. For example, this lady came in at 13 weeks, and what we see is a very nice stomach bubble. But unfortunately, in the later, at the mid-trimester scan, what we find is a stomach in the thorax, and so this was a congenital diaphragmatic hernia. So we have to tell the lady that this was something which was could not have been detected in the first trimester. Evolving anomalies means the anomalies evolve as it goes, and this particularly applies to skeletal problems. So this can be seen in short limbs and achondroplasia, as well as heart abnormalities where the stenosis becomes greater as the heart grows, and then has to pump more. Late onset anomalies, again, they may not even be there in the first trimester. Some may not even be there in the second trimester. And examples of late onset anomalies are fetal tumors, ovarian cysts, microcephaly, ventriculomegaly, not related to spina bifida, but may be related to infection or a brain hemorrhage, and agenesis of corpus callosum. Now, late manifest anomalies means that these anomalies show up when as a result of the fetal physiology. So when there is increased urinary production, it masks a urinary tract obstruction. And when there is increased fluid production in the lung or fluid collection in the lung, then it unmasks a congenital pulmonary airway malformation. Now, as you can see, around 12 weeks, this was the views, and you really don't see something like this. So for all purposes, the kidneys look normal, but then around 22 weeks, when she came in, there was hydronephrosis with kernicterus. Resolving anomalies. Now, as you can see, at 13 weeks, there was an extracystic structure, which was actually an abdominal cyst. And although we did tell the lady that nothing to worry, call her back, she didn't come back. So I don't know what she's done. But then this is one category of anomalies which actually resolve. The other anomalies which that will resolve are megacystis, exomphalos. But unfortunately, there's a very high threshold to termination in our scenario for various reasons. But it has to be borne in mind that these anomalies do resolve, which means if a lady comes to you later and there's no megacystis, it doesn't mean the first scan was wrong. No, this megacystis is just resolved, it just went away. And the other thing is VSD. VSDs are also known to close. There may be absence of indirect clues. Now we know that in open spinal bifida, actually what sets up the tick is actually the clues that's shown in the fetal head. Now this is a case in the first trimester. As you can see, the shape of the fetal head looks very normal, and whatever views I'm getting of the spine, it also looks normal. But unfortunately, these were the findings of the mid trimester, wherein there is a 11-shaped head, which actually gave a clue to look at the spine more carefully. And there is indeed, sadly, a spina bifida. There's also findings of questionable significance. Now, this is a choroid plexus cyst. Again, choroid plexus cysts are quite common. So what do we tell them? In fact, the incidence of choroid plexus cysts, I think the first trimester is somewhere 5 to 6%. And in this mid-trimester, literature quotes 2%, all this a little higher. But one should remember that cystic structures in the choroid in the first trimester are completely normal. And this was what is proven in this case. So this is a nice chart taken from Dr. Palladini's book, wherein he gives them, the ones in blue says that these structures, blue indicates that this is the earliest time that we can see the structure. So the earliest time we can see a stomach and kidney bladder are the 12, 14 weeks. And the plus in black indicates the best time or the ideal time to see. So as you can see, the ideal time to see most of the structures is around 19 to 21 weeks. So this again should be an important counseling point when we're talking to the patient, either before the scan or after the scan. So which means there is a role for an early anomaly scan. Now, early anomaly scan, again, one should have a low threshold to suggest this, and this should be done in any instance where we find that the first trimester scan, whether we're doing it routinely or whether we're doing it in a high risk, which means there are indications that something could be wrong. In both the scenarios, we should have a very low threshold for suggesting an early anomaly scan, which is normally done around 16 to 17 weeks. So as you can see from this image, now at the first trimester scan itself, this is the lower limbs, and these feet really didn't look right. Now, persistently, it was not, not upright as it should be. And of course, doing a TVS, got a better view, and there was a suspicion of a talipes. So called her back around 16 weeks, and sadly, this is what is there. There is a talipes. Of course, she continued the pregnancy, and the baby had postnatal care. So early anomaly scan should be taken recourse to when there are limitations in a first trimester scan for whatever reason. So in conclusion, if you know, you will look, and if you will look, you will find. So gain the expertise, know the background, follow a standard protocol, invest time on scan, and maintain a low threshold for second opinion or a rescan. Thank you very much.
That was an excellent presentation, Dr. Supriya. I thank you very much for having simplified as to what we can look and what we can ignore and how we can enhance to what to look for, as you rightly said, that we need to definitely be on the alert zone. And it's so heartening to see that about 95% of anomalies can be detected in the first trimester by 13 weeks itself. And only few, like what would be missed in the first trimester would be asked to go for the second trimester scan or an early scan in 16 or 17 weeks. it's so reassuring that we can reduce the trauma to the patients when detected early. I would like to ask you one point here, that is there any role now, after having seen such beautiful slides, to go in for a invasive study or the NIPT or the double marker, that because the scan itself is so evident and this can beautifully show us what anomalies could be there in the first trimesters. Both to you and to Dr. Pratima.
See, if we see a structural anomaly on the scan, you should not do NIPT, full stop. Because I showed you there is a 60%, 40%, more than 1 in 3 chance that you'll find a chromosomal abnormality there. So NIPT is not going to help, because remember, NIPT is a screening test, right? So structural anomaly, invasive test, nothing else. Okay. Double marker, no, because double marker is also screening test. We will talk about aneuploidy screening in another talk, because it will be too much. I think if we just stick to anomalies, it will be better here, right? Yes. So I hope that I have made that clear. You've got some case presentations. So if I can get Ashwini or Aarti, who's going first? Okay. Aarti is online.
Yes, ma'am. Yes, ma'am.
So if you can just share the screen and just go through some cases, because that will help us to understand what we have done in these circumstances, and then we can kind of come back to the discussion. Yeah, go on, Aarti.
Yeah.
Share the screen on the first.
Yeah. Good evening, everyone. I'm Dr. Aarti, clinical fellow at BFMC. I'll be presenting few first trimester anomaly cases.
Please share your screen.
Not visible, ma'am. I've shared.
Okay, share your screen. Anand?
Share.
Hello?
Share.
Hello?
Yeah, we can see it now.
Yes, madam.
Yeah. Is my screen visible now?
Yeah, your screen is visible, and please make it slideshow.
Yeah, and my first case today is Mrs. ABC, who is 27-year-old, tribi gravida, consanguineously married to her maternal uncle. She is conceived with ovulation induction. She was referred to us at 12 weeks for a routine scanning. And these are the scan findings on ultrasonography. There was acrania, and the brain tissue was protruded outside the skull. So the diagnosis of acrania was given, and this pregnancy resulted in termination. So coming to the discussion part, acrania, this is one of the lethal NTD, neural tubal defect. The prevalence is about 1 in 1,000 at around 12 weeks of gestation. And as all of us know, it is a sequence, acrania, it is absence of cranium, further leading to exencephaly, in which the brain tissue protrudes outside, and eventually that will lead to anencephaly when whole the brain tissue is resolved. So usually it can be isolated or associated with chromosomal abnormalities. In 50% of cases, there can be associated chromosomal abnormalities. But usually when it is isolated, the chromosomal defects are rare. And the recurrence, if there is a previous one affected child, the recurrence rate is about 5%. And if the mother has 2 previous affected child, then the recurrence rate will be about 10%.
Yeah. So the question here comes as somebody is asked whether we should do a karyotyping when it is an isolated NTD. As Aarti already clarified it, if it's an isolated neural tube defect, it's unlikely to be associated with chromosomal abnormality. However, if you have multiple defects, then the chances of chromosomal or even genetic abnormalities or even recurrent neural tube defects can be associated with certain genetic variations, and in those situations, very useful to karyotype or even do a microarray. Right. Go on, Aarti.
Yes. Yeah, coming to the prevention in the next pregnancy, the woman should be offered folic acid 5 milligram tablet along with the vitamin B12 at least 3 months prior to the conception, and also it has to be continued in the first 3 months of pregnancy. And there is also an option of activated folic acid, that is quadrifol, 800 micrograms. This is useful in a woman with methyl tetrahydrofolate gene mutation, where the conversion will not happen. And what we advise in the next pregnancy is the woman should have an NT scan at around 12 to 13 weeks. And always do for a transvaginal scan for the spine in the subsequent pregnancy during NT scan. And also call a woman for early anomaly scan at around 16 to 17 weeks. Coming to my...
Can I intervene here?
Yes, ma'am, yes.
Yeah. What is the earliest gestational age at which we could be able to pick up the anencephaly or the microcephaly?
Anencephaly, acrania, see, anencephaly is usually terminology that is used in the second trimester or early second trimester. Anencephaly is the same as the acrania, because in the first trimester, all you see is the absence of the skull. And it is always diagnosed after 11 weeks, not before 11 weeks, because it can be hypomineralized. It can appear hypomineralized. So I will always wait for the 11-week scan, 11 weeks to be completed to call it acrania. Because many times the brain matter can be intact. So when your brain starts dissolving, that's when you start getting those features of anencephaly.
So do we have to wait for 10 to 11 weeks before we label it as an anencephaly?
11 weeks plus before calling it
11
acrania.
weeks. Okay. And to detect, there's another point I would like to get clarified. How frequently can we do the first trimester ultrasound? What would be the minimum? I mean, how many times we would like to call the patient for the ultrasound in the first trimester after she misses the period and she comes for a confirmation of the pregnancy?
No, see, if you're doing your early pregnancy scan, I mean, most of you do your early pregnancy scan around 7-8 weeks, I would presume. So you bring her back at 11 weeks, 12 weeks plus, so you can see the anatomy better as well. So once, I mean, see, it is not the number of times, it's to do more with the completion of the scan. The scan must be completed. Sometimes it can take 2-3 sittings, because if the baby is not helping, then, or if you have a very busy day and the baby is not helping you at all, then you ask them to come back the next day and complete the scan. What is important is to follow the guidelines and complete your list, whatever protocol you have set yourself for. As a beginner, your protocol will be milder or smaller or shorter, but later on, as you progress in your training, you should include more and more things to be able to see in the first trimester. Because as a beginner, I think it will be unfair to make you look at the heart. At least start with your target 9, and then you start building up. And once you're experts with your target 9, then you go for the next one, then you go for the next one. So that's how you build your training.
Yeah, okay. The message is loud and clear that 11 weeks plus on, then we can label it as microcephaly or
acrania, anencephaly, not microcephaly.
Acrania and anencephaly. And yes, from then on, we start looking more intensively for the anomalies. Thank you. Please go on with the second case.
Go on, Aarti.
My second case is Mrs. ABC, who is 30-year-old, primary gravida, spontaneous conception, positive blood group, non-consanguineous marriage. There was a family history of diabetes and hypertension. She has come to us for routine first trimester scanning. And these are the imaging findings. In the first image, you can see there was an increased end. There was an evidence of fetal hydrops. And on the measurement, the head circumference was less than 5th centile in this baby. Also, there was an absence of ductus venosus. So in view of above findings, we have counseled the couple for invasive testing, and the mother underwent chorionic villi sampling, and the karyotype it showed Turner syndrome, that is monosomy X0. We had also counseled the couple about the guarded prognosis in this pregnancy, and the couple chose to terminate this pregnancy. So this was an hydrops, non-immune hydrops. So the non-immune hydrops is an accumulation of fluid in at least two of the cavities, either in the skin or in the cavities. That is, it can be pericardial, pleural, or ascites. The causes, as all of you know, there can be so many causes for hydrops: chromosomal defects, infections, structural defects, metabolic disorders, tumors, so on. And investigations, because whenever we see a hydrops in the first trimester, we should rule out the chromosomal abnormalities in that fetus. So we have to offer an invasive testing. And coming to the recurrence rate, whenever there is a fetal defects infection, there is no increased risk of recurrence in the subsequent pregnancies. If it is a part of trisomies, the recurrence rate can be about 1%. And if it is a red cell isoimmunization, recurrence is high. And in metabolic disorder, the recurrence rate is about 25%. Coming to my third case, Mrs. ABC, who is 36-year-old, primary gravida, spontaneous conception, positive blood group. BMI was 34.3. She was non-consanguineously married. She was referred to BFMC at 12 weeks in view of exomphalus. And these are our imaging findings. There was a huge anterior abdominal wall defect, and a whole of the liver and bowel were herniated through that defect. And the parts of the fetus were seen outside the amniotic cavity. And even the cardia was seen lying outside the amniotic, outside the fetal body. And there was a severe kyphoscoliosis in this fetus. And fetus, it also had an increased NT, which was measured at 244 mm. So we have counseled the couple. We have counseled this body stock anomaly, which is a lethal anomaly. And it has a low risk of association with the chromosomal abnormality.
So here you would see that, there's a difference between the exomphalus and body stock. Now, body stock exomphalus has got a much higher association with chromosomal abnormalities. And then you would wait to see whether the bowel only exomphalus would get resolved. Whereas the body stock anomaly is completely the opposite. It's a bad one, it's a lethal one, and you just basically terminate this pregnancy. So therefore, the diagnosis, when you suspect something, it's very important that you get to the bottom of it in terms of ensuring that the rest of the baby is looked at and you have a proper diagnosis, because the outcomes can vary for these pregnancies. Okay, so amniotic band syndrome, yes, almost, yes. Severe form, yes, because part of the baby is lying outside the amniotic cavity, and it is, it's got a very short cord, so that is pretty much the same. Yes, Ashwini, go on.
Yeah, interesting.
Good evening, everyone. I'm Dr. Ashwini, presenting the next two cases. My patient is 32-year-old primary gravida, non-consanguineously married, spontaneously conceived with no significant past of family history. She got a double marker done elsewhere, which showed increased risk of trisomy 21, that is 1 in 37, referred to BFMC at 13 weeks. At 13 weeks, when she came to us, we could see a spinal defect, that is open spinal defect involving the lumbar region, measuring about 8.1 millimeter. On axial plane of the head, we could see there is a crash sign, which is positive, increased nuchal translucency with reversal of brainstem and BSOB ratio. The patient was counseled regarding the guarded prognosis. Chorionic villus sampling was offered, microarray came to be normal, and the couple terminated the pregnancy. Coming to the markers of spina bifida, the biparietal diameter less than 5th centile will raise a suspicion of open spina bifida. The other signs can be the crash sign. That is, here you can see the mesencephalon is crashing over to the occipital bone, and there is obliteration of the arachnoid space. And the dry brain sign, the name itself says, is a leakage of the cerebrospinal fluid leading to the reduced CSF in the biparietal plane, and the choroid plexus completely fills the lateral ventricles. Coming to the cisterna magna or the intracranial translucency, either they can be non-visualized or they can be less than the 5th centile. And the other sign can be the brainstem to brainstem occipital bone ratio, which is raised, that is reversal. The 4-line view, which are usually seen, that is brainstem, intracranial translucency, cisterna magna, and the nuchal translucency may not be visualized properly in the parallel line. Coming to my next case, 19 years old primary gravida, non-consanguineously married, conceived spontaneously with no significant past or family history, was referred to BFMC in view of suspicion of congenital heart disease. At 12 weeks, 6 days, there was no flow across the tricuspid wall, and there was abnormal 3-vessel view, which raised a suspicion of transposition of great arteries. On counseling, it was found that father was born to a consanguineous couple, was diagnosed with a double outlet right ventricle with ventricular septal defect and pulmonary stenosis, underwent Fontane's procedure. In view of this, genetic counseling was offered. The couple were counseled regarding the guarded prognosis. Invasive testing was offered. Fetal echocardiography was suggested after 4 weeks, along with consultation with the pediatric cardiologist. However, the couple decided to go for termination of the pregnancy. Coming to the cardiac defects in first trimester, usually 1% of the pregnancies will present with congenital heart diseases. 3 times the risk gets increased if the first degree relative is with congenital heart disease. There is an entity called inherited cardiac conditions, where the few cardiac conditions can be autosomally dominant in inheritance. The other cardiac defects which can be inherited are categorized as familial cardiomyopathies, that is hypertrophic cardiomyopathy, dilated cardiomyopathy, or ARDCs, familial arrhythmias, that is long QT syndrome, short QT syndrome, or Brugada syndrome, Marfan syndrome, and sudden arrhythmic death syndrome. Coming to the cardiac defects which can be seen in first trimester screening, usually always detectable are pulmonary atresia, tricuspid atresia. Mostly detected are hypoplastic left heart syndrome, atrioventricular septal defects, complex heart diseases, and left atrial isomerisms. Never detected are ventricular septal defect, pulmonary stenosis, aortic stenosis, tumors, and arrhythmias.
Basically, we have seen a case of spina bifida. We see the markers of spina bifida. Then we see, cardiac defects. You can either look from the markers for, screening for cardiac defects. You can even detect major cardiac defects. So it's important to understand that if you go looking for these things, you're more likely to find, right? And if you don't look at things directly, at least look at things indirectly by looking at the markers, right? So that is what that teaches us. Yeah. And of course, sometimes the father could have heart defects that they have not told us about, and we find in the fetus, like in this particular case, the father had a heart defect that came up only after we detected the heart defect in the fetus. So beware that it's not just the maternal history, but the paternal history also is as important. Right? So go on, Pallavi.
Good evening, everyone. I'm Dr. Pallavi, Clinical Fellow at BFMC, presenting next 3 cases. This is ABC, 29 years old, primary gravida, positive blood group, was consanguineously married to her maternal uncle, IVF conceived. There was no significant past and family history, was referred to BFMC at 13 weeks, 2 days in view of omphalocele and increased NT in twin 1. So as you can see in this image, there is a big abdominal wall defect containing liver as a part, and the umbilical cord is seen on the top of it, which is confirming the omphalocele. So this was a discordant anomaly in a dichorionic diamniotic twin. So couple was counseled regarding the selective reduction of twin 1 with omphalocele and CVS for the normal twin to know the karyotype, and the karyotype of the twin 2 came to be normal. So couple continued the pregnancy with twin 2, and she delivered at 40 weeks a female baby weighing 2.8 kgs and doing well at birth. The prevalence of defects in multiple pregnancies, same as in singletons, that is 2%. So the risk of defect per pregnancy comes out to be 4%. Most of the times, the 90% of the defects are discordant. That is, one fetus is most of the times is affected and other is normal. Because of discordant anomaly, there is increased perinatal mortality of the normal co-twin. So the management can be done expectantly or by selective fetal reduction of the abnormal twin. But the selective fetal reduction carries a risk of miscarriage and preterm labor, and this risk increases as the gestation of the reduction increases. My next case, she was 22 years old, non-consanguineously married, primi gravida. There was no significant past or family history. She was referred to BFMC at 13 weeks in view of abdominal cyst. At our center, these are the ultrasound findings. There was a big bladder seen, which was measuring around 12 mm. So after doing the risk assessment, the risk of trisomy 18 and 13 was increased. So we counseled the couple regarding the chromosomal association and advised invasive testing. Usually megacystis is diagnosed when the bladder size is more than 7 mm, and the chances of obstructive causes are more when the size is more than 15 mm. It is due to the retrograde pressure on the kidneys. So vasocentesis is advised to assess the renal functions, and if required, vasoamniotic shunt was advised. So she came to us for the follow-up scan at 14 weeks, 5 days, and the bladder size was found to be 19 mm. Patient opted for CBS along with vasocentesis. At 15 weeks, the bladder size was 33 mm and vasocentesis was done. There was a karyotype was suggestive of 46 chromosome with 22 with mild addition of 22 on 22 chromosome. So genetic consultation was done, and it was found to be an abnormal karyotype, and couple opted for termination. So whenever there is a megacystis or any structural anomaly, we should always go for a detailed anomaly scan to look out for other associated anomalies. Urinary system examination should be done in detail. As told earlier, we should offer the karyotype, the renal function. In view of therapies, we can go for vasoamniotic shunting and then if the cause is the posterior urethral wall for the obstructive uropathy, then the cystoscopy with the ablation of the posterior urethral wall can be done. My next case, Mrs. ABC, 34 years old, primi gravida, spontaneously conceived with positive blood group, referred to BFMC for nuchal translucency. There was increased nuchal translucency and left congenital diaphragmatic hernia was found with mediastinal shift. As you can see in this video, in the thoracic cavity, along with the heart, there is a stomach bubble seen, and the heart is pushed to the right side. So this is diagnostic of left congenital diaphragmatic hernia. So the risk of trisomy 21, 18, and was increased, and there was also the higher along with the congenital diaphragm due to the increased nuchal translucency. The couple was counseled regarding the risk of chromosomal abnormalities, and a guarded prognosis was explained to the couple, and they opted for termination of pregnancy. Congenital diaphragmatic hernia is a difficult diagnosis in first trimester. Early displacement of the stomach into the chest leads to the early diagnosis. There will be usually a mediastinal shift. If there is an increased nuchal translucency, please definitely look for the localities like chromosomal defects, mainly the trisomies, that is 18 and 13. Or there can be Pellister-Killian syndrome. Genetic syndromes are found in 10% of the cases, and the most common is Fryns syndrome. In case of CDH, once it is diagnosed, so the karyotype is recommended. Detailed anatomy scan with fetal echocardiography is recommended, and fetal MRI is of questionable opinion regarding with such an early
as the ultrasound also carries almost the same diagnostic potential, especially in the left-sided congenital diaphragmatic hernia. For the prognosis, if it is a part of trisomies, then it has a lethal outcome. If it is isolated and with severe disease, then the survival rate is 15%. The moderate disease, survival rate is 50%, and with mild disease, survival rate is more than 90%. Then there is 1%, and if it is a part of syndromes, there is 25% risk of recurrence.
Anand, you're there?
Thank you.
I've muted myself, sorry. Yeah, I think that was the last case. So
Yeah.
we should be able to discuss questions. I think there are some questions asking about NIPT and increased nuclear translucency hydrops. I think we will keep that for our section on chromosomal abnormalities or aneuploidies. Let's concentrate on defects if there is anything unanswered or any questions raised at this point of time.
Madam, of all the cases, abnormal cases picked up and presented, nearly 9 to 10 cases, of special interest was this case on bladder distension, megacystis. Most often we consider or label it as maybe the post-urethral wall, and it's a wonderful learning that we intensively have to evaluate this patient to rule out the chromosomal abnormalities, and there definitely could be chromosomal abnormalities associated just with the bladder distension. So not to take it easy, and the message conveyed loud and clear that whenever we have congenital abnormalities, please look for karyotyping as well. Any questions? I think we started about 10 minutes late, and we
In fact,
have another
in
15
one
minutes.
of our megacysters, we even had a translocation downs.
Okay.
And that was an IVF pregnancy with the donor egg. And the father was normal. So it was the donor egg that had the translocation.
Correct. Sometimes we also find megacystis in the late, I mean, in the third trimester as well, at 28 weeks and 30 weeks around. Yeah. Is it so? Does it happen so that with congenital abnormalities, they can even present later on in pregnancy?
Yeah. If they can sometimes present later on, you can have completely normal kidneys and bladder. But suddenly, you know, in the second half of the pregnancy, you can have huge hydronephrosis and megacystis.
Hydronephrosis,
Yeah. Those ones will be more amenable to vasecotherapy, vasicocentesis and shunt. Actually, they probably will be maybe relatively better.
Yeah. Thank you. That was an excellent array of cases that we had. It was a treat to know that so many things can be picked up at such early on in pregnancy. Sanjana, can we have the questions?
I'm already, Pratima ma'am discussed mother, like we'll go through these questions in next slide.
Yeah. For the aneuploidies, we will discuss.
I think you have seen the slide. Chat box notiralla ma'am.
I'm checking on that. Yeah. And there was also for megacystis, I think she's already answered that megacystis we must do karyotyping, yes. Because there are, in fact, there is another genetic condition called megacystis microcolon as well, which is autosomal recessive condition. So
yes.
It is important.
Yes. There's another question.
Fetal abnormality is not complete till we actually have the answer of why it is there. Because fetal abnormalities are not supposed to be there. Unless we know the reason why it is there, we have not really done our job completely.
Ma'am, one question from Dr. Tarun Ohra, like choroid plexus cyst can also be placed in resolving type of anomaly.
In the first trimester, usually you do not see choroid plexus. Supriya, I think you want to answer that question because you had that case with choroid plexus.
No, Dr. Tarun, you put it in whichever category you want, no problem. You can call it resolving, you can call it uncertain significance. So the point we should convey to the patient or to the referring clinician is, it is quite common. In fact, I remember many years back, Dr. Simon Ma, in fact, drove home the point to us that choroid plexus first trimester, don't bother. So, put it whichever category, but tell the patient really not to get alarmed. No setting of alarm bells. Call her back, of course. Call her back.
Yeah, but that should set off your own alarms to make sure that you check the rest of the baby thoroughly.
Yeah, another thing is it's
So
not
calling something isolated is a huge responsibility.
Yeah, and also it doesn't come in the category of anomaly. It comes in the category of a soft marker, which is actually variations of normal.
So you have a huge responsibility when you call it isolated. Don't call it isolated till you're checked out for everything.
There's another question like
yes, ma'am. One more question, like whether first trimester biometry is helpful to put a growth chart.
I mean, I don't know if I understood it right, but then are you talking about plotting growth of the baby? One thing we should understand that most of the growth occurs 28 weeks onwards. Now, why is it useful when you talk about first trimester biometry? I don't know if you're talking about BPD, HC and all that. No, those are not, we will not take recourse to that first. We will take recourse to a CRL first, and that's what's important to do a correct CRL. Now, for some reason, in the very, very rare instance, we can't get a good CRL and we want to date, then we will look at BPD. But we don't start assessing growth from there. No. Growth normally, if everything goes normal, is only from 28 weeks upwards.
I told you the idea of measuring something in the first trimester is that you've seen it in the correct plane. That is why you measure. So you make everything non-measurable. That's what Kipros always says. Anything which you see it subjectively, you make it measurable. So you put a stamp on it. Right? So there's another question here, micrognathia with single umbilical artery. Is this associated with any syndrome or genetic problem? Yes. Micrognathia is a marker for trisomy 18. Single umbilical artery is also a marker for trisomy 18. So yes, chromosomal abnormalities, but also single umbilical artery can be associated with many renal anomalies as well.
Hello? Ma'am, mute Adri.
No, I got muted by the host.
Okay. There was a disturbance, I think, from other. Anna, unmute madri, madam. Hello?
She's audible. Yeah, go on, madam.
Yeah. Okay. Am I audible now? Right.
Yeah, yeah.
It's okay. So, yeah. So, micrognathia, very important. It is associated with chromosomal abnormalities and with genetic syndromes. Again, coming back to single umbilical artery, something like choroid plexus, it's a marker, but you make sure that there is nothing else associated, and then you would call it isolated.
Ma'am, one more question by Dr. Piyush. What if buccal edema at 10 weeks and get resolved after 1 week, that is after 11 weeks?
He has to attend our next webinar on aneuploidies. No, it can happen. It depends how much the nuchal edema is really. Because yes, you can still have chromosomal abnormalities. Many of them can be normal as well.
That's why I answer.
Because both, yeah, go on.
In fact, in a study they had only 35 number of cases, but half of them were normal. So nuchal edema less than 11 weeks, no. I mean, we do look out. Of course, there's no point telling her.
Just keep your antennas up.
We have to look out, but 50% of them will be normal. The other ones will have aneuploidy, or they may have a miscarriage as well, or they may have an infection.
And depends how much the nuchal edema is as well. We've had trisomy 21 also, we've had normals also.
Yeah, ma'am, one more question by Dr. Bhuneshwari Surgalli. That is, gestational age determination is in first trimester, whether it is done in 7 weeks or 8 weeks onwards.
Yeah, it's actually, see, the guidelines say 8. Now they call it good practice point and they call it some evidence base. So they say anywhere from 8 weeks to 13 weeks, 6 days. But remember, these guidelines are coming from countries where, early pregnancy scan is not part of their protocols. So in our country, because we do an early pregnancy scan for a lot of good reasons, I would say that, even if you want to stick by guideline, we have to assign EDD or confirm the EDD when the CRL is at least 10 millimeter. Now that corresponds to 7 weeks. But if you want to stick to the guideline, 8 weeks upwards. Well, there's no point like we see a lady around 6+ weeks and say, no, you don't fall into that category where we can date you and come back. No, date her. And if you do it correct, and then call her back for 12 weeks. By then you will.
Anyway, yeah, you can reconfirm it 12 weeks. So there's no big rush about it. between 8 and 12 weeks, there is no big hurry to date a pregnancy, right?
Yeah, I think, I mean, since early pregnancy is passion, I think we should have an early pregnancy webinar also, because
Actually, yes.
if you go to date at early pregnancy, again, it's very important how you take the fetus. You can't take the fetus, right? And you have to zoom the image, because very, very small millimeter difference at this stage will mean a large difference later. So if you want to date at 6.5, 7 weeks, make sure that your images fall completely within protocols.
I think that's Rajeshri, Dr. Rajeshri, that's another webinar, early pregnancy only.
I get the cues.
Full,
Absolutely. Yes.
because now they're
anything,
only 2-3 hours. I think,
we just didn't realize how the 2 hours.
And cover it.
Yes, yes. We just didn't realize how the 2 hours went by. And it's been so interesting to hear more from everybody.
And we have not even covered like 1% of what you should.
Yeah, absolutely. Absolutely. There's so much.
We'll be waiting for other sessions, ma'am.
I'm sure all of us are.
Yes.
Okay, fine. So
Any more questions?
it's a lovely audience, and I think very interactive as well. That makes a lot of difference to us.
And we had 160 plus people who have logged in. So that's a very good response for an evening to stay on for 2 hours, unwavered. And the count was the same from the beginning till the end. So wonderful job, madam. Congratulations. And definitely we should
Congratulations to you too. I think everybody did a good job.
Good job. Yes. The case scenarios, the selections, the presentation, the jugalbandi between you and Dr. Supriya as to why and why not and what if and what not was excellent. And thank you so much. Thanks to the audience as well.
Thanks so much, everybody. Have a
Ma'am,
lovely
a brief vote of thanks by our committee member,
Oh, sorry.
like Dr.
Okay,
Supriya.
fine.
So
Yeah.
Supriya, let us thank you, ma'am, for giving beautiful lecture. Supriya.
Thank you. Thank you.
Hello.
Please unmute, ma'am.
Yes, ma'am. Yes, ma'am. So, good evening, all. Hope all of you had a wonderful evening with the excellent webinar on first trimester anatomy scan, as much as I did. I, Dr. Supriya, from on behalf of Fogsi Kalaburagi, wholeheartedly thank Dr. Pratima Radhakrishnan ma'am and Dr. Supriya Shishadri ma'am for sharing their, for spending their evening with us and sharing their vast experience and valuable knowledge in the fetal medicine. Each of the sessions were very practical, as what to do, how to do, and what is the next step if any abnormality is detected, and how to identify the normal as normal and label the abnormality as an abnormal. So the last segment of case discussion was cherry on the top, which answered most of our queries and clear any doubts we had. The take-home message of the inverted pyramid of antenatal care, that is shifting the screening to first trimester and not missing the target 9, that is the most detectable and always detectable anomalies, was very well taken. I sincerely thank Dr. Vidya Thobi ma'am for chairing the today's session. Thank you, ma'am. Lastly, a big thank you to the Fogsi President, Dr. Rajeshri Palladi ma'am, and Secretary Fogsi Kalaburagi, Dr. Sanjana Talur ma'am, for organizing or arranging this much informative and clinically relevant topic on the fetal medicine today. Thank you all the audience for being connected till the last. Hope we had a wonderful session, and we take some tips and tricks which have been shared by the pioneers in the fetal medicine in our day-to-day practice. Thank you all. Thank you so much, ma'am.
Thank you.
Thanks,
Thank you,
Anand.
Anand.
Thank
you and
Anand.
congratulations. Thank you and congratulations.
Thank you. Thank you.
Thank you.
Bye. Bye. Bye.
Good night, ma'am.
Thank you, ma'am.